gears here a little bit. So what we've done for you today is kind of painted the picture of what is heroin, how did it get into our county, what's the impact on our county, and our next presentation is going to move into the science of addiction and the effective treatment. Our next presenter is Dr. Andrew Tompkins. Dr. Tompkins is currently an assistant professor in the Department of Psychiatry and Behavioral Sciences at the Johns Hopkins School of Medicine. He received his MD from New York Medical College and an MHS in clinical investigation from Johns Hopkins Bloomberg School of Public Health. He is board certified adult psychiatrist, a fellow in the American Psychiatric Association, as well as a diplomat in addiction medicine from the American Society of Addiction Medicine. He was previously the co-medical director of the Behavioral Pharmacology Research Unit Opioid Treatment Program. Sorry. He currently studies the use of medications for the treatment of opioid dependence, opioid withdrawal, and pain in persons with a history of addiction.
So I wanted to say thank you for letting me come here, and hopefully what you'll get out of my talk is that addiction is an illness, it is a disease. It's a chronic disease, the disease of the brain, but there are effective treatments, and treatment does work. So I'll be repeating those phrases over and over again, so hopefully by the time you leave, you'll know that. So a little background about myself. I grew up the son of a preacher in rural Kansas, and I thought addiction was a moral failure. I thought perhaps, if you just said no and you just stopped, people should, not have any problems. As I've grown up, as I've gone through my training, as I've had a lot of interactions with people with addiction, I've come to learn otherwise. And hopefully, through this talk, which is a very quick overview, you will also have the same understanding of addiction as well. So I'll start with some terminology about what addiction is versus substance use disorder, which is the clinical diagnosis. I also like movies, so I'll have some movie references throughout my talk. One that's recently come out, Fast and Furious, I think 7. So it'll be a fast and furious overview of addiction science. We'll talk specifically then, moving from general to specifics, what we're here all to do today, on opioid use disorder. I'll talk about the 4 concepts of disease, how it relates to that. And then I'll focus on treatment, and if I have time, which I probably won't, each person is individual. There are special populations which should have different treatment plans for them. So terminology. We've used the word addiction, which is a great term. Addiction, as defined by the American Society of Addiction Medicine, is a compulsive drive to take a drug despite serious adverse consequences. The American Psychiatric Association defines and uses the term substance use disorder. I'll be going back and forth because I think they're pretty similar in their definitions. But substance use disorder, as defined by the American Psychiatric Association, is a problematic pattern of use of alcohol or other substance that significantly interferes with daily life and continues despite consequences. So you're taking the drug over and over again. You may try and stop. You may have consequences, but you can't stop. You might not be able to read this, but hopefully I can go over it a little bit for you. So the DSM, which is the Diagnostic and Statistical Manual, which is sort of how we diagnose substance use disorders in the treatment community, has recently been updated to DSM-5. It was released last year by the American Psychiatric Association, and sort of combined 2 previous diagnoses, which was substance abuse and substance dependence, into one diagnosis itself of substance use disorder. In order to qualify for that, a person has to have 2 or more of the following symptoms within a 12-month period. And is a continuum. So, if you have 2 symptoms, you have a mild substance use disorder, you get more symptoms, moderate, and finally, if you have a lot of symptoms, 6 or more, you have a severe substance use disorder. And based upon what you have, we'll sort of say what kind of treatment you may need. So what are those things that a person has to have? You're taking a drug in larger amounts than originally intended. You have a persistent desire or unsuccessful efforts to cut down or control your use. A great deal of time is spent on activities obtaining the drug. Craving, which was recently added as sort of this overwhelming internal drive or desire to use the substance. The recurrent use despite a failure to fulfill major role obligations. So you're using despite being a mother, a father, a brother, an employee, a coworker, a student. All of that doesn't matter anymore, just the use of the substance. And it's continued use despite those adverse consequences. The last things that are mentioned there are tolerance and withdrawal, which are just two aspects of a substance use disorder. Tolerance, and we'll go into what those terms mean, but basically you're having to use more and more of heroin or another substance to get the same effect. And withdrawal is when you suddenly go without that drug, which you've been taking every day for an extended period of time. You go through a physiological syndrome. In this case, we'll talk about opioid withdrawal. However, as you notice, you don't necessarily have to have those to be criteria for a substance use disorder. I will not be using the terms addict or alcoholic. Those were original terms back from the 1950s, which were used by society to refer to patients with substance use disorders. However, they've developed since then a pejorative connotation, and they're being used mainly to put down people. However, if you're a member of a 12-step program, you might hear a person identify themselves as an addict or an alcoholic when they introduce themselves at a meeting. And this is a way of helping a person identify with the program so that they get enough buy-in to start the 12-step program and enter into recovery. However, as a clinician, I will use the term substance use disorder or addiction. As I said, movies, I really like movies. And here we have just 3 movies that have come out over the last 50 to 60 years which have talked about addiction. The one on the left is called Days of Wine and Roses, which was a famous movie from the late 1950s, early 1960s, in which you have 2 people who become married, suffer with alcohol use disorder. And the movie involves the recovery of the husband while the wife continues to use alcohol and the problems that are associated with that. Traffic won a couple of Oscars back in the early 2000s. Involved 3 stories of the Drug Enforcement Agency, of the drug czar in the United States, of persons who are dealing or the cartels, and sort of intersects with all the problems that can happen when a society is trying to combat the trafficking of drugs. And finally, we have Train Spotting, which is a movie that has sort of become a cult classic and shows Ewan McGregor, who's the larger character there, suffering from heroin use in Great Britain. And he actually goes through opioid withdrawal, which is actually a very good representation on film of opioid withdrawal. So if you want to go back and see that. And what happens is he's trying to engage in recovery, get away from the life, but the life of addiction keeps coming back to him. So those are just 3, but there's a lot more out there. Not every one of them is a good movie, of course, but there's a lot of things that we can learn from the use of media. So I mentioned at the beginning that addiction or substance disorder is a disease. But if you take a step back, and you might ask yourself, well, what makes something a disease? And so I don't know if has anybody besides Dr. Chen been to medical school? Good. So we use I think we still use a specific textbook, Robbins' Pathologic Basis of Disease, which talks about what a disease is amongst all the systems of the human body. And so it's an abnormal pathological condition that affects all or part of an organism. And so basically something goes wrong within the human body, and then it starts to create havoc, and it can affect just a specific portion of the body, it can affect a large part of the body. And there are 4 aspects before something can be called a disease. It has to have a beginning, so an etiology. It has to have a pathogenesis, so what happens, what is introduced to the system, what causes changes. There are those morphologic changes, so what can we see in terms of addiction? What can we see that's happening in the brain that happens as a result of taking substances? And finally, all that stuff as a clinician you rarely see, so how does a person look when they're coming in with a problem? What are the things that you see? What are the things, the lab values that you can check? And what is the clinical significance of that syndrome? So 4 aspects of a disease. And what I've had here is comparing and contrasting something that we all think of as a disease, type 1 diabetes, versus substance use disorder and addiction. Do people know anyone with type 1 diabetes? Very much more common. I put a steel magnolia there, so there's a movie about one of the characters who suffers from diabetes. And so basically, it has an etiology, it has a beginning. So basically, there's an autoimmune destruction, so the body turns against itself and destroys a very specific part of the pancreas. And if you actually look at that, there are many different types of cells within the pancreas, but the beta cells are the ones that produce insulin. So basically, you destroy all those cells, your body no longer makes insulin. And you can actually look at that under a microscope. And finally, what happens when a person doesn't have insulin? They come into their provider with very classic symptoms of having very high blood sugars. And if it's too high, the person can become very confused. They can actually become uptundent, they can go into coma, and they can actually die. It's not something that can be cured. We haven't found a cure for diabetes, but if you replace that insulin in a person with type 1 diabetes, they can live a relatively normal life. They can do things just like we all do, get married, have careers, have children, but they have to take care of it every day. So I'd like to say that addiction or substance use disorder is also a disease. It has an etiology, it has a beginning. We know that there are certain individuals that are genetically predisposed to developing addiction. We know that early life experiences, such as sexual trauma, can predispose people to developing addiction. And finally, you actually have to take a substance in order to finally start to develop a problem with that substance. So if you had all these risk factors, but you never found the substance, you weren't going to develop that substance use disorder. And so what happens? What is the pathogenesis? So once you have the substance come into your body, over time, you're going to find changes in specific parts of the brain, because that's what we think of is the organ that is under fire in addiction. And there's a specific part of the brain called the reward pathway, which involves a substance called dopamine, which I'll go into a little bit later about what that is. But dopamine and its pathways change in the brain. And because of that, and you can see these changes right now under a microscope if you're dealing with somebody in the post-mortem or if you're dealing with preclinical research. But usually what you'll see is you can actually take a look at a person's brain using specific imaging technologies, MRI, CAT scan, PET scan, and you can see that there have been changes in the brain as a result of chronic use of substances. However, you as the clinician will probably rarely see that, but what you will see is somebody coming in with the clinical characteristics that I mentioned previously that were put forth in the DSM-5 of how a person would present if they had a substance use disorder. And again, it's chronic. Unfortunately, our treatment system was originally developed as this is an acute illness. We get people off of a substance, everything should be fine. But as we've known through research, we know that substance use is a relapsing chronic illness. However, with proper treatment, a person with addiction can go on to have a relatively normal life. They can have a family, they can have a job, they can be very, very successful in whatever career that they choose for themselves. So, brief overview, type 1 diabetes is an illness. Addiction, I believe, also is a disease. Here I have I have some data throughout my slides, but this is from a famous article from the Journal of American Medical Association in 2000 by McClellan and colleagues, and shows that chronic illnesses like addiction, like diabetes, are chronic and they relapse. So you might not be able to see those, but basically greater than half of individuals will have some type of relapse once they've developed the criteria for drug addiction. And what that will be is a return to substance use. Similar rates are seen with diabetes, so return to not having insulin, developing high blood sugar, hypertension, so not taking your medications, or over time, even if you're taking your medications, your blood pressure goes up, and asthma. So we all know kids that, if they take their medications, they're fine, but sometimes they don't have access to their medications. Or even if they're taking them, they have an asthma attack and need to go to the emergency room. So over half of all individuals will have a relapse of those conditions, and that's just another piece of evidence showing that addiction itself is like a lot of other chronic illnesses and needs to be treated as such. So again, if substance use disorders are diseases, what part of the body is affected? And like I was taught in the 1980s, addiction is a brain disease. However, and although I will be focusing a lot on the brain itself, there are multiple other parts of a human person that's affected by addiction. There are biological, psychological, environmental factors that contribute both to the development of addiction and also contribute to both treatment and then relapse itself. So what I have here are nice pictures, hopefully, of slices of the human brain. And what we have from top to bottom is a normal individual. What we're looking at here is normal function. So I have a nice little graph from purple to red. I guess in this instance, ravens don't matter, but I guess capitals do matter. So the more red and yellow you have in the brain, the more normal the brain is functioning. However, if you use, and we've used cocaine here, but we can also do opioids. If you use cocaine chronically, you get less and less activity within the brain itself. And even if you stop cocaine for 10 days, you haven't gotten back to normal. Even if you stop cocaine for 100 days, You haven't gotten back to normal. And now we've started to see that there may be some permanent changes to the brain that happen once a person becomes addicted to a substance. So no matter if they take that substance out and live the rest of their life, parts of the brain will no longer function as normal. And we have to consider that in our treatment options. So we talked about the brain. How does the brain work? I'm not going to give you a whole lecture about that in an hour, but I will give you some brief parts about what it does. So a brain is a collection of neurons, the type of the cell that's in the brain, and those neurons communicate with each other, and through that communication, we get movement, we get emotions, we get sleep, we get all the things that make a human being a human being. And one of the ways that cells will communicate with each other is through the use of messengers that I will call neurotransmitters. And all that means is it's a chemical that allows the neurons in the brain to communicate with each other. And I like to think of as a neurotransmitter as a key. We all know what a key is. It opens our doors, it opens our car, it starts the engine. But you have to put that key into a lock. And the way that the body has a lock is a receptor. So a neurotransmitter is released from one cell, it binds a receptor on another cell, and starts a process of communication and change that can lead to high, that can lead to you feeling hungry, that can lead to you feeling good or feeling sad. So all that can be affected by the communication, and a lot of that is involved in addiction is done through neurotransmitters. So I mentioned dopamine before. Dopamine is just one type of neurotransmitter, and it can cause pleasure when released in certain brain areas. It's the pleasure you feel after running, it's the pleasure you feel after sex, it's the pleasure you feel after eating a good meal. All of that comes down to dopamine. However, you release normal amounts of dopamine. However, when you introduce a substance into your body, you release much or super normal values, which give you that sort of euphoric or high that people will talk about when they get use of substance. Now again, dopamine is only one of those types of transmitters. Ones I won't talk about today are GABA, but we as human beings weren't designed evolutionarily to take heroin. That's not our purpose in life. However, heroin, what it does is it takes advantage of chemicals in the brain called endorphins, natural chemicals, which have natural receptors. And so it takes that over and gives you more of a high, more of problems that eventually turn into substance use disorder. And it all started because we have these natural neurotransmitters in our body, the endorphins, which have opioid receptors to do their normal function. So I have a couple of pictures here, used with permission by the National Institute of Drug Abuse, NIDA. And what you have is sort of the representation that we've just been talking about. The top of that is a cell, it's a particular type of a cell. Within it, if you can see, are circles. And within those circles, or over there, are the neurotransmitters themselves. And what you'll see a little bit later is that those will be released and go down to the cell that's underneath it. So there we go. We have the dopamine being released from one cell. It's acting as a key. It's going into lock with the dopamine receptor, which are the blue cones at the bottom. However, once it's done its job, the way that the body gets rid of it is it has these reuptake proteins, the red things, that grab the dopamine and bring it back into the neuron so that it stops working. It turns itself off. However, there are substances like opioids, like cocaine, that interfere with that, either release much more dopamine than usual, or prevent the red things from coming in and cleaning it up so the dopamine stays around a lot longer than usual. And we know that through a lot of science that we're trying to go over briefly for you today. This is your brain, and I'll show a picture of what your brain is like on drugs. So there's a lot more to the brain than just the dopamine system. The other thing I'd like to talk a little bit more in detail about is sort of your front of the brain that we call the prefrontal cortex. And that sort of serves as an executor. So, there are these drives that you have, the drive to sex, the drive to survive, the drive to feel good. But you don't want to do that all the time, or you won't get the other things that you want to do in your life done. And so you have the front of the brain, the prefrontal cortex, which says, we shouldn't do that, we should go to work, we should make a paycheck so that we can do other things in our life. However, as we'll see a little bit later, these parts of the brain are developing at different times in your life. So you're not just born an adult human being, you have to develop, and your brain is developing for 25 years. However, the reward pathway, the part in the middle that controls the high, is ready to go at about adolescence. So that's why adolescents want to feel good all the time, because that part of the brain is now working. The front of the brain, the prefrontal cortex, develops much later, to late adolescence, up until the age of 25. So you don't develop that executive functioning until much later, and that's why addiction we think of as a developmental disorder, because a lot of people start using during that adolescence phase, and we don't have the executive functioning that we would later on in life. Questions about that? Okay. So here are finally one last series of pictures. It shows that we can actually look at the dopamine receptors using this PET imaging. In this same case, the Capitals are good, the Ravens are bad. And so you see a lot more receptors that are available to be bound by dopamine in a normal brain, which is on the left side. And then on the right side, you have a brain after a person's used cocaine for long periods of time, alcohol for long periods of time, and heroin for long periods of time. And so what you see is less red and less yellow. So the body tries to combat having these substances in the body all the time. And so what the brain does is it develops changes so it can start to function normally in the presence of a lot more of a substance, in this case opioid. And the way it does that is it says, well, okay, so we're having a lot of the keys around, we can't stop that from happening. But if there are no locks, or there are less amounts of the locks, then you're not going to get the side effects that are associated with having too much opioid in the body. And that's one of the changes that happen. Again, dopamine is only part of the story. Scientific research has shown that other neurotransmitters are affected. There won't be a test, by the way, at the end of this. This is just for your information. But serotonin is involved in regulating mood and sleep. Glutamate is involved, it regulates learning and memory. And as I said before earlier, the body actually produces natural opioids, which we call endogenous opioids. And this is just a picture of those pathways. So this is just another slide that we went over a little bit earlier. The prefrontal cortex, the executive part of the brain that says, don't do this, you should do the good things that you want to do, develops later than the reward pathways. That's just another pictorial representation of that. So we've already used the term opiate a lot, or opioid, and there is a difference, and this slide just goes to make sure that everyone understands that difference. So they're both narcotics, which are a super-inducing drug. They function normally, when used normally, as analgesics or pain control, and they also can reduce your sensitivity to pain. However, opiates themselves are derivatives from the opium or the poppy plant, and opioids includes those, but also refers to any drug that activates the opioid receptor. So there are a lot of opioids that we make in the lab, like you've heard fentanyl, but I'll show you a picture of a lot more of those. Anywhere that they bind to opioid receptors, we've been talking about the brain, but there are opioid receptors throughout the body. It's why some of the side effects of chronic use of opioids include constipation, because there are receptors in the gut system. It's why people on heroin have a greater risk of infection, because there are receptors on the immune-fighting cells, the white blood cells. Again, I'm from Kansas. And so you're not in Kansas anymore, we're in Anne Arundel County. However, heroin itself, and then morphine, is derivative from poppies, and that's just a nice picture of, in The Wizard of Oz, Dorothy is traveling to the Emerald City with her pals, and they go through a poppy field, and they suddenly are fallen asleep, because that wicked witch is trying to prevent them. That's it. So, how many people laughed? So, endogenous opioids, what are those? There are three main types. And again, these are opioids that are made in your body for normal purposes. They're endorphins, they're enkephalins, they're dynorphins. And what these do, besides the heroin and besides the opioid analgesics that you put into your body, they're required for a stress response. So the fight or flight response involves a lot of opioid euphoria during sex. So the humans have a drive to procreate, so we can keep ourselves going on. We have an appetite, which is it's partially controlled by opioid receptors, and also your body temperature. One of the other things that opioid receptors is involved in is nausea and vomiting. So you might notice that certain individuals vomit a lot when they take an opioid. That's because they're triggering the vomiting center in the brain. So all these symptoms, all these things that you have and you see in front of you, there is a reason behind them within the brain itself. And this is just another picture. Opioid receptors are in the brain. They're in different parts of the brain. And what we're hearing today about is people dying of opioids. And the reason why they die is that there's a center within your spinal cord, the bottom part of the brain, which is your drive to breathe. And if you put enough opioids in your body, you're stopping that drive to breathe. And so people stop breathing and they die. And it's all a function of the drug is doing its job. The drug is going into your body, it's hitting the receptors, it's blocking the activity it's supposed to do, but in this case, it's killing the person. You've already heard about heroin, so I won't go over that again, but heroin is actually a pharmaceutical product. It was developed in 1874 by Bayer, and was marketed as heroin. And heroin is actually from the German word heroisch, meaning heroic. Unfortunately, heroin is not heroic anymore. And eventually, so it was actually developed as a treatment for addiction. It was because people at that point had become addicted to morphine and codeine. And the reason why it's so addicting itself is it can get into the brain much faster. So you get much more of the drug put into the brain to do much more of its effect to give you that high. And at the time, physicians believed heroin was a safe alternative to these drugs because it was not habit producing. We might have repeated this past with the production of analgesic agents that we thought were not going to be problematic, but unfortunately have become problematic. So if you don't remember the past, you're going to repeat it. So we talked about where it comes from and different types of heroin. So here's a nice picture. Unfortunately, it doesn't list all the opioids that are available for the treatment of pain. And I'm not knocking opioids for the treatment of pain. I hope you're not getting that message. Opioids, there are chronic painful conditions that only respond to opioids. And people can take them successfully, and people can not develop addictive disorders. But the risk you run, the risk we've been seeing, is that you put a lot of that into the community, you're going to develop a lot more addictive disorders, and you have a lot more deaths. And so we as a society have to develop that balance. And I'm just here to be the messenger, and you guys sort of can decide what the balance is and what the treatment options that you would like to put out there for your community. So we're going over a lot of things about addiction, about it's a brain disease, about what it does, what changes it happens in the brain. But let's focus now specifically on opioids and opioid use disorder. So again, opioid use disorder is just a substance use disorder, which is a compulsive drive to take an opioid despite serious adverse consequences. Here we have a nice little rat. So the way we study addiction in the lab is one of the ways is to have rats press a lever multiple times before they get food, before they get heroin. And you can actually train a rat to like heroin and do a lot of work to get heroin. And then hopefully what you can do is then develop treatments to stop that process. So I have a cute little rat here saying they'll press levers for food. Again, opioid use disorder is a disease. We've learned about the core concepts of disease, etiology, pathogenesis, morphologic changes, and the clinical syndrome or significance. So let's go over those in specifically. Etiology, it's like I'm going good on time. So again, I said this before, but most people who go on to develop opioid use disorders start their use in adolescence. They may not necessarily develop a problem until later, but the use itself will start in adolescence. However, that pattern is changing, as you heard previously, that there are now significant numbers of individuals who start with legitimate prescriptions for opioid analgesics and then go on to develop opioid use disorders. And so, again, there are risk factors that are well known and well characterized. Family history, so if your mom, your dad has an opioid use disorder problem, you're more likely to have one yourself. You're more likely, if you have a psychiatric illness that besides addiction, to develop addiction. If you're using other substances, so we're not going to talk about the concept of a gateway drug, but we also know that a person who uses marijuana, a person who uses alcohol, or any other substance is more likely to develop a problem with other substances. I said this earlier, it's not just about the brain, it's about how the brain functions in the environment. So the environment can include your early childhood experiences, and those individuals that unfortunately come from a pattern of sexual or physical abuse, later on in life can develop problems with opioids. And these are just things for you as providers to think about, how are you going to address that, which may be driving partially the use within your treatment plan. We've heard this even before. If you're a man, you're more likely to develop a problem than a woman, although women, of course, develop this problem as well. And something we've also talked about is opioid availability. If you don't have any opioids in the country, you're not going to develop an opioid use disorder. I don't think we can get rid of opioids, but I'm just saying that that is one factor to consider. And finally, we've heard about this, your peer group. So if you belong to peers that use, you yourself are more likely to use. And that's just a short list. of the risk factors, but I'm just showing you how these are patterns that persons have that we can study, that we know over and over again lead to problematic opioid use and then opioid use disorder. So why does a person use in the first place? And this is something that's still very interesting. It's probably, it's a function of genetics or opioid receptors. Some people, when they use opioids, feel high. They get a euphoric response, and that they begin chasing, that can eventually develop a problem with it. And some people actually have underlying psychiatric illnesses, and they use it and they start to feel better. Not everyone has that. A lot of people will tell you, I used heroin or used this, and it wasn't good, so I went on to something else. But there are certain individuals that when they use it have these instances. However, even if you don't have that at the beginning and you use it every day for a legitimate purpose, such as pain, your body becomes dependent upon it, physiologically dependent, and starts to function normally without it. So that if you go without it, so you run out of your prescription, or you can't get in contact with your dealer because it's snowing. A person with addiction works 24 hours a day to go get their product. So even if in the snow again, people are out on the streets looking for heroin in Baltimore. It is a tough life. And the reason why they're doing that is because if they don't have the opioid, they start to go through a syndrome of withdrawal. And we'll talk a little bit about what that is, but it's really, I like to think of it when I'm first introducing it to the audience as a really bad case of the flu. And if anyone who's had the flu, you throw up, you get nauseous, you can't eat, you have diarrhea, you might feel cold and hot flashes. All of that happens when somebody doesn't have an opioid. And so people go on to develop the next phase of their illness where they're just using to feel normal. They're just using so they can get out and do the rest of the things that they want to do. And they're no longer able to feel high. And that has to do with the concept of tolerance. So you get to a point where you can't have enough of the drug in your body to feel that euphoric response. And so you're using just to feel normal. But a lot of that has to do with the receptors, which we talked about earlier, but also has to do with the rising and falling of opioid in the bloodstream. And I think Kelly will talk about that a little bit later in her talk. So what does a person in opioid withdrawal look like? So again, this is a brain illness, so we know that there are brain changes that happen. And when you don't have an opioid, you basically get a supercharged level of brain activity, which can lead to 3 types of symptoms that are physiologic, so the ones we talked about earlier, nausea, vomiting, diarrhea. You get high heart rate, tachycardia, your blood pressure goes up, people sweat, and their pupils dilate, so they get very wide. And then you have psychological symptoms, so people feel anxious, they feel dysphoric, or they have a depressed mood. It's really a bad state of affairs. And the one thing that I'm very interested in as a researcher is people develop widespread pain even though they haven't had an injury. We call that hyperalgesia. Now that's just the initial phase of withdrawal. So you can take a person off completely of an opioid and that phase will go away, but there's a somewhat controversial protracted abstinence which goes on for much longer. Again, probably because the brain, it doesn't get back to normal. And it was discovered actually when we first looked at opioid withdrawal back in the 1940s in Kentucky, that people didn't go back up to normal for 6 months or longer. And what was the most problematic that people talked about was the inability to sleep or insomnia. So that's a large component, and something that treatment providers have to think about is, we know that this is going to happen. How are we going to address it? How are we going to let people know that that doesn't necessarily mean that they're not getting well? It's just they're not getting well fast enough that they want to. So again, there's that pathogenesis, and then there's the morphological changes that we can see. So we talked about opioid receptors themselves. So there's a decreased amount of them in the brain. So you have less of it. And then the receptors themselves are changed so that even if you put that lock into the key, you're not going to get the same level of response from the cell, the same level of high as you get. And that's called tolerance. I love that, changing back and forth. So I like to think of it as a new set point in your brain has developed. When I first bought a house, I had a water heater that I can set the sort of temperature, and I can change the temperature of how hot it's going to get. I do that, and I do that because maybe I want a little bit hotter water, maybe I have a child, I don't want to get it so hot. There's a new set point. And the brain itself develops a new normal, a new set point when it has a lot of opioids in the system. And so therefore, it is looking and acting as if it's going to have an opioid every day because it's always had an opioid every day. And so when you don't have it, and because that new set point involves a lot harder work on the function of the brain, you take away the opioid, which is blocking you now have a rush of brain activity, a rush of neurotransmission, which causes the opioid withdrawal syndrome. So again, the last part of the disease, what does it look like? We've already talked about that. You'll have a person come in that will meet the criteria set forth in the Diagnostic and Statistical Manual, as well as looking for objective markers of opioid use, such as urine drug screens. We also have standardized measures to measure opioid withdrawal, such as the Clinical Opioid Withdrawal Scale, or the COWS. And as well, another reason why opioid use disorder is very clinically significant, we're talking about here, which is opioid overdose deaths. But there are other health risks, including suicide, HIV transmission, psychiatric illness, and a host of other things. So it is very important. But I'm probably preaching to the choir. At the beginning, I said opioid use is a chronic illness, and this is another little bit of data. And what you see is somebody who followed opioid users for up to 33 years. And so that's very hard to do, if anyone's been in the treatment field, to find somebody who's been using heroin for 33 years. And what you have, sort of the natural history of what happens when somebody starts to develop opioid use disorder, is there are three types of individuals. The least common is the ones that go high use very quickly, stick around for about a couple of years, and then slowly over time, either through the use of treatment or not treatment, stop their usage. But they stop usage about 8 years after their first use. And that's only 8% of the population. The majority of individuals are those that develop sort of a stable high use, those that are just using to feel normal, and it can go on, this is 16 years. But they never stop that level of use. And then there are individuals that do have that high level of use, and then after 12 to 13 years, they come down. And they may come down, this doesn't tell you why that is, they might come down because they're in treatment, they might come down because they can't afford it, because they lost their job, they might come down for other reasons. But what is it that is showing you is that heroin use does not go away once it's established itself in an individual. And so you have to develop treatment programs that are going to follow somebody for lots and lots of years. The thing at the top, which is very important, is that opioid users enter treatment an average of 8 times before they start to stay abstinent. So one, that's important for treatment providers, but it's also very important for people thinking about how to combat this illness, that it's not going to be a one-time fix. It's going to be a long fix. And they're going to be failures before there are successes. And so how are you going to address that? Very sobering news, but I'm an optimistic person, and I want you to realize that there are treatment available, and treatment does work. Here we have a person walking towards the light in the tunnel, and that light hopefully is treatment. There are different types of treatment that a person can have. There are multiple treatment providers in the area. They probably have multiple different ways of treating an individual. Originally, it was thought that you just take people off the drugs, you detoxify them, and they get well. There are two ways of detoxifying somebody. You can do it on an inpatient or residential basis. You can do it on an outpatient basis. However, the vast majority, or 80% of all individuals who go through detoxification, relapse to opioid use within the next year, and most of that is within the first 2 months. You get higher, and then if you're even those individuals that start treatment, a large majority of them don't actually finish treatment if all you're getting is detoxification. You get higher rates of completion if you're in an inpatient setting, but even that isn't very good. So therefore, the recommendation now by most providers is that a person be given long-term maintenance therapy for opioid use disorder, and by long-term I mean greater than 12 months. And there have been people, of course, that have been on it for decades. So maintenance treatment can involve 3 types of opioids. There are the full agonist opioids, there are partial agonist opioids, and there are opioid blockers, naltrexone being. And so what we have here on the x-axis, you have increasing amount of the drug. And on the y-axis, you see an effect. And it could be any effect. It can be euphoria, it can be respiratory depression. If you're a full agonist, and here that means methadone, so think methadone, a full agonist. The more methadone you get, the more of an effect you get. There's really no stopping of that until, of course, a person overdoses and dies, which can happen on methadone. Buprenorphine is a partial agonist because you increase the dose, you still get that sort of linear relationship, so you get more and more of an effect, and then you reach a plateau where if you increase the dose, you don't get problems. And you can think about it in your head that's actually probably a good thing for safety issues. And then you have an antagonist. So an antagonist is also a key that goes into the lock, But instead of actually turning on the cell, it turns off the cell and prevents it from being turned on by the other potential opioids in the system. So the more naloxone or naltrexone you give to the individual, you don't get an effect in terms of opioid positive effects. You block it, and you continue to block it. And each one of those can be effective for treatment. But I just wanted to tell you that there are 3 types of maintenance treatment: full agonist, partial agonist, and antagonist. And they all work. Now again, this is agonist replacement therapy. So why does this work? And what's the philosophy behind giving somebody who's addicted to opioids another opioid just for treatment? And if you think about it, there's a very good reason for that. And it goes back to sort of the analogy I drew to type 1 diabetes. So in type 1 diabetes, a person destroys all of the parts of the pancreas that produces insulin, so it now requires insulin from outside the body to function normally. But once they have it, they function normally. So if a brain who's been used to having lots and lots of opioids around, and now requires higher doses of opioids than a normal person would have to function normally, why not just provide that amount of opioid in a very safe and effective manner? Then what we would think would be good, we just take away that opioid and you go back to normal. As I said earlier, that just doesn't happen to the brains of persons who develop opioid use disorder. So now you've developed a need for an opioid coming from outside the body, inside the body, to be treatment, so that the person can function normally. Ideally, what this medication, this opioid would be, was it would be something that makes the person less likely to get high off of it. It only has to be taken once a day. Heroin itself, sometimes you have to take it much more often than that, because it only lasts a certain amount of time in the body. So you'd like this drug to stay around for 24 hours or even greater. You'd like the physicians or the providers to be able to do it. So there were federal laws passed in the early 1900s which said physicians legally cannot, or they'll be put in jail, give an opioid for the treatment of opioid use disorder. And so that took an act of Congress to change that. And as well as there's other state and local laws that sort of govern, what type of treatment is available in certain areas. So that's also something for persons involved in politics and government to think about what kind of changes can be happening on the state or local level to allow greater access to treatment. And lastly, you'd like this drug to have a favorable safety profile. So even if you took more of it, because persons with a history of addiction are very, very likely to take more of it, just because that's the nature of their drug. So you want them, even if you do that, to have a favorable safety profile, so that even if you took more of it, you wouldn't have necessarily that effect. I've been focusing on the brain and focusing on getting the brain back to functioning normally. However, as I said earlier, that is not the only thing needed by persons with opioid use disorder. And I'll talk a little bit about psychosocial treatment a little bit later and how that is can be very, very helpful for individuals in terms of their treatment course. So methadone, I mentioned, was a full agonist. It was shown to be effective from the 1960s. It was discovered either by the Germans or by Americans in the 1940s, but when, as was mentioned earlier, people were returning from the Vietnam War, President Nixon was really worried about an epidemic of opioid use disorders, and so he wanted a treatment at that time developed. And so methadone itself is long-lasting. So it lasts for greater than 24 hours. You only need to take it once a day. It's typically at a methadone center given in an oral form. In this case, it's red because it's cherry flavored. It can be really any flavor. Again, it's a full mu opioid agonist, and it's used, unfortunately, or fortunately, whatever, depending upon how you look at it, only federally licensed treatment centers can dispense methadone for the treatment of opioid use disorder. And so what usually happens is patients come to the clinic daily for medication. Sometimes if they do well, they can actually come less than once daily. And then staff provide much needed psychosocial interventions at a sort of a case-by-case basis, individual therapy, group therapy. We talk a lot about psychosocial rehab because people who develop this problem usually don't have an education or have lost the education. They don't have a job. They've been incarcerated, so they have a lot of issues around that. And all the whole person needs to be rehabilitated. And it starts with allowing that person to function normally without having to do illicit activity, and then start to get back to the rest of their life. Buprenorphine. So that came around in the early 2000s in the United States because it's a federally FDA-approved drug for the treatment of opioid use disorder. And it's currently the only medication allowed to be dispensed by qualified physicians, and again, it's only physicians at this point, for the treatment of opioid use disorder in an outpatient clinic. So any physician, no matter what their specialty, can take an 8-hour course and get what's known as an X waiver, and then start treating persons with opioid use disorder. Now, unfortunately, there's a limit on the number of individuals that a person can treat. The first year, that limit now is 20, and then it goes up to 100 individuals after that, if the Department of Health and Human Services says it's okay. Again, I said it has a better safety profile, meaning that you can take more and more of it, and there's less likely for you to, if you're just using buprenorphine, to have an overdose. You can overdose, of course, if you're using other drugs or other mood-altering substances. When you're providing buprenorphine, you're not required to provide psychosocial treatment. You just have to have a way to refer people outside if they need that treatment. So there's been a lot of studies, a lot of them have happened in Hopkins here in Maryland, that have tried to say, well, is buprenorphine better, is methadone better? And what these studies have shown is that they have about similar efficacy in terms of getting people to stop using illicit opioids and keeping people in treatment so that they can get their lives back to normal. So not one or the other is better overall, although there might be certain individuals where it's good for them to go to a structured setting, a methadone clinic, or other individuals it's good for them to go to a clinic at a doctor's office. That's really dependent upon the individual itself. So lastly, we have naltrexone. So you've been talking about naloxone, which is the acute sort of overdose treatment. But if you give it in a once-a-day pill form or a once-a-month injection, you can basically block the effects of all other opioids. And if you think about it, if a person is using an opioid because they want to get high or the reinforcing effects of the drug, if you block that drug from happening, they won't get that, so therefore they should go back to doing what they want to be doing, which is the rest of their life. So again, it's available in pill form or injection. Unfortunately, it's hard to get insurance providers to say yes to. So the prior approval process for this can be a little bit hectic for physicians or other providers. But the good thing is it also has been FDA approved for the treatment of alcohol use disorder. So if your person has an alcohol problem and an opioid problem, this might be a drug to hit both of those. When looking at this drug in terms of clinical trials, which is how we evaluate whether a drug is good, it works, but it doesn't work as well as methadone or buprenorphine, and that's usually because the people stop taking it. Because they're not getting high, they're not getting a pleasurable effect, they're not getting any effect, unless they're highly motivated to not use, which there are certain groups of individuals that are, like healthcare professionals that develop problems. This drug isn't as effective as methadone or buprenorphine. I'm not focusing a lot on psychosocial treatments today because what I've been trying to do is focus on evidence-based treatment, and now there are a lot of facilities that provide psychosocial treatments. They include long-term residential, therapeutic communities, intensive outpatient programs, outpatient drug-free. So I work in an outpatient drug-free program right now. It's a dual diagnosis program at Johns Hopkins Bayview, as well as the traditional 28-day program, which with insurance is now less than that. And the reason why I don't talk a lot about them is not necessarily because they don't work. They actually do work, and you'll get people who've gone through them and turn their lives around, which is really what I want to do when I see a person, as I really want to give them their life back. But there are a few controlled comparisons in the literature that have shown comparing the psychosocial intervention to opioid maintenance treatment. What usually happens is if we add a psychosocial treatment onto opioid maintenance, does that improve it? And the answer is sometimes, usually. That's the answer. Long-term treatment has been effectively shown to reduce and stop opioid use. However, long-term is usually greater than 6 months of treatment, and usually it's removed from the environment the person is living in. The problem with that is they go back home, and without any sort of further treatment, the relapse rates of the use are very high. And what this is showing is, again, this is a chronic illness that needs chronic treatment. And so hopefully if a person is in a residential treatment, they go back into a continuum of care back in the place that they lived, and they continue to receive treatment. Narcotics Anonymous is actually also a wonderful program itself. It's based upon the 12 steps that were originally developed by Alcoholics Anonymous. The groups themselves are independent. They have a basic text. And usually it's persons who are farther along in recovery bringing their knowledge of abstinence and recovery to persons who are younger and just trying to quit using the drugs. There are very little evidence from controlled studies showing efficacy as a sole treatment. Usually what they have looked at is what's known as 12-step facilitation. So how can we get people to go to 12-step meetings? And what we know is that if people go to 12-step meetings and they go to more 12-step meetings per week, they tend to do better than those that don't. Now, is that because you get more motivated people who continue with treatment, or is there something else going on? We don't know that, but we do know that if you get people there and they're involved in other treatment programs, they're more likely to succeed in terms of stopping use and continuing in treatment than those that don't. So, about 10 more minutes. I want to stop for questions, but just briefly remind you that this is an individual. These are not sort of numbers, these are not sort of gross numbers of patients, these are individuals with very different life experiences, and so therefore there are individualized treatments that are needed. And so, first off, a person isn't just using heroin. They're most likely using lots of other substances, and the treatments that I just talked about, maintenance therapies, only work for opioids. They're not going to stop you, unless you're naltrexone, from using other substances. So you have to think about that. Opioid use disorder patients often, more often than not, have a comorbid mental illness, and so how can you as a treatment program provide the much needed depression or bipolar or schizophrenia or other type of treatment that, if untreated, people are more likely to continue to use. Pregnant women, so agonist treatment is safe and effective for use in pregnant women, but there are a lot of other things that are needed to make sure that mother and developing baby are okay. A lot of our patients, as we said before, have comorbid chronic pain, and a lot of times if people don't have their pain treated, they're going to continue to use. But if they continue to use, they're more likely to get pain, and they're more likely then to want to continue to use again. So that's something we actually don't have very much information at all about, and that's my particular area of interest that hopefully in 5 years, maybe more, maybe less, give you more information about what successful treatments are. Incarcerated individuals, we've shown that starting or continued maintenance therapy while incarcerated leads to less recidivism, so that's something for you guys to think about. And we've been talking about adolescents. Unfortunately, the medication-assisted treatment, only buprenorphine has been FDA approved for patients under the age of 18 and just 16 to 18. And methadone itself is only approved for those individuals that are 18 and older. And so we don't necessarily have the agonist treatment available for adolescents. But we've shown it can be effective, but we don't have long-term studies showing that a person necessarily needs to be on it for as long as an adult needs to be on it. So again, there is effective treatment, but how effective it is and how long a person has to remain on these drugs is still an open question for us to debate and consider. I have my contact information, so if you want to contact me after it, I definitely love talking to people. And I'll end with one of my favorite movies, Scarlet and Arrow. Frankly, my dear, I know treatment works. So, thank you.